Hi, this is Philip Ador, founder of NCLEX RN 45-Day Challenge. In this video, I'm going to be talking about third trimester bleeding. Bleeding in the third trimesters of pregnancy can range from spotting to life-threatening hemorrhage. Remember that the term, a woman's total blood volume must increase by 40% and cardiac output has increased by 30%. 30% of cardiac output goes to the gravid uterus, so significant bleeding can be quickly catastrophic. The objectives of these videos are to list the causes of third trimester bleeding, to describe the initial evaluations of a patient with a trimester bleeding, differentiate the signs and symptoms of third trimester bleeding, list maternal and fetal complications of placenta previa and placental abruptions, describe the initial evaluations and management plan for acute blood loss, list the indications and potential complications of blood product and transfusions. The causes of a third trimester bleeding include placenta previa, placental abruption, preterm labor, uterine rupture, vasa previa, as well as the vaginal or cervical tear or lacerations from the intercourse or cervical polyps or severe cervicitis. We will focus on the first two on the list, which is the placenta previa and the placenta abruption. The first 5 causes can lead to serious neonatal and maternal morbidity and mortality. The last 3 on this list are considered the benign causes of third trimester bleedings and the ABCs of cardiopulmonary resuscitations. Don't forget, in a pregnant third trimester patiently bleeding, there needs to be another B for a baby. Remember to always assess the fetal heart rate status as part of the initial evaluations of the third trimester bleeding. Once you are assured that the patient is stable and that there is a reassuring fetal heart rate pattern, then carefully history should be obtained. Here are the PPQRST mnemonic. It's helpful to frame your questions. P. Is there a pain with the bleeding? P. Placenta. Has she had a formal ultrasound during the pregnancy that assesses the placental locations? Q is the quantity of bleeding. R is recreational drugs during the pregnancy. S is sex recently, and T is the timing of the bleeding. Then move on the physical examinations. Look at the maternal vital signs. Again, remember to assess the fetal heart rate to ensure that there is a good IV access if you're concerned about the heavy bleeding. Look at the skin carefully for petechiae. Palpate the uterus to assess if it is soft or hard or tender. Remember, do not perform cervical examinations until the placental locations has been confirmed. Speculum examinations can be performed to visually assess the cervix. Let's now discuss placenta previa care. Is the uterus with the external os, internal off in the endometrial cavity. Complete previa completely covers the os, whereas the marginal previa partially covers the os. The classical presentations for the placenta previa is painless vaginal bleeding. Placenta previa is diagnosed by ultrasound. Remember that with the placenta previa, a digital cervical examination should not be performed, for digital manipulations can cause bleeding. If there is heavy bleeding, volume resuscitations and possibly betamethasone for fetal lung maturity, the management of placenta previa less balance the risk of prematurity with the risk of heavy vaginal bleeding. Delivery with the placenta previa should be performed via cesarean sections. Let's now discuss potential complications with placenta previa. Let's now discuss potential complications with placenta previa. There can be bleeding from the lower uterine segment with placentals with abnormality attached. In addition, there can be abnormal extensions of the placental tissue. Placenta acerta involves extensions of the central tissues into these superficial layers of the myometrium. Increta involves extensions further into the myometrium, and percreta involves extensions completely to the myometrium, the serosa, and sometimes into the adjacent viscera. Note that the depth of the invasions corresponds to the alphabetical order. These three abnormal placental extensions are associated with significant bleeding and morbidity. Cesarean hysterectomy need to be performed for these three conditions. Let's now discuss the placental abruption. This is abnormal separations of the placenta, and classic presentations is vaginal bleeding with abdominal pain. There is usually painful vaginal bleeding. Now that there can be concealed bleeding if the blood is trapped behind the placenta and cannot exit. The term convolular uterus refers to the extravasations of the blood into the uterine musculatures, which causes the uterus to appear purple or blue. Risk factors for placental abruptions include trauma, switches in motor vehicle accident, domestic violence or fall, cocaine use, hypertension, and multiple gestations. The diagnosis of placental abruptions is by clinical examinations. The management of placental abruptions involves monitoring other vital signs, fluid administrations, close monitoring or fetal heart rate pattern, and delivery for severe hemorrhage. Note that the abruption is the most common cause of coagulopathy in pregnancy. Managing acute blood loss, obstetrical hemorrhage is one of the leading causes of massive blood transfusions, along with the trauma, ruptured abdominal aortic aneurysms, and liver transplant. Massive blood loss transfusion is defined as the transfusions of greater than 10 units of packed red blood cells in 24 hours. Remember that 1 unit of packed red blood cells is approximately 200 cc's of red cells and should raise the hematocrit by approximately 3 to 4%. Key point to remember is that oxygen delivery is greater than the 4 times oxygen consumptions, so there is always enormous reserve. So if an intravascular volume is maintained during the bleeding and cardiovascular status is not compared, oxygen delivery can be maintained until bleeding becomes too excessive. This is why it is so important for anesthesia colleagues to aggressively give IV fluids during a hemorrhage in order to maintain the intravascular volume. In case of massive transfusion, if only red blood cells or crystallite volumes to be administered, that they'll be diluted to a plasma clotting proteins. 1-to-1 ratio reflects a ratio of a unit of fresh frozen plasma to 1 unit of packed red blood cells to 1 unit of platelets. To discuss when do we decide to give a blood transfusions, we have to consider the risk of transfusions and the desire to avoid an unnecessary transfusion. Case of massive hemorrhage, the need for transfusion is great in order to avoid significant morbidity and mortality. The patient's overall health status and blood counts will help with the decision making. In general, when the hemoglobin is 6 to 7, a transfusion is recommended between 7 and 8. The transfusion should be strongly considered, and between 8 and 10. The transfusion needed generally only in the patients that have symptomatic anemia or acute coronary syndrome. The risk of blood transfusions that must be considered are the risk of infections. The risk of HIV is approximately 1 out of 450,000 to 650,000. The risk of allergy or immune reactions at risk for volume overload. The final point to remember with third trimester bleeding is to remember to give program to Rh negative.